This session is Embodied Friendship. Welcome again. My name is Dominic Vachon. I represent Compassion Care Medicine. Great to have you here, and I'm really happy to introduce and moderate this session. As you already know, the way we are doing all these sessions is each group will have 20 minutes, and then we'll save questions for the very end. And we'll go from there. All right, welcome. Our first speaker is Lauris, Dr. Lauris Kaldjian from University of Iowa College of Medicine. He will be speaking about why physicians need friendship.
It's a great pleasure to be here with you this morning. Am I speaking loudly enough for you? No, okay. And I'm going to grab one of these. Thank you. Is that better? Excellent. Okay, good. So my topic this morning is physicians and why they need friendship within their professional communities. Specifically, I would like to focus on features of friendship that are increasingly vital to the flourishing of physicians at a time when social and economic forces are continuing to change some of the practices of medicine in ways that undermine traditional understandings of health and approaches to health care. By limiting my focus to physicians and their professional friendships, I certainly mean no disregard to the goodness and necessity of friendships physicians have outside of medicine. And by focusing on physicians, I don't mean to disregard other healthcare professionals, and what I say about physicians is presumably true about all who work in the healing professions. To anticipate the destination of where this talk is going, allow me to point in advance to one profound aspect of friendship that lies at the center of my concern for medicine: the role of truth in the love that binds friends. For friendship is a love between fellow travelers who are walking toward the same goal, a bond between those who share and delight in sharing a vision of what is real and good and of what matters most. For physicians, you might call this vision the soul of medicine, that animating set of beliefs, values, principles, and virtues that not only defines the purpose of medicine and the content of professionalism, but also inspires the personal commitment that makes one willing to give of oneself for the good of others by caring for those in medical need. Friendship between physicians is predicated on and nourished by a shared vision of the truth, a truth that must be large enough to encompass the broad landscape of medicine. But we must be quick to note that this landscape is not unbroken, for it is fractured by disagreements among physicians themselves regarding the foundational beliefs and values that determine what we believe health is and what healthcare ought to be. But before commenting further on this troubling state of affairs, let me briefly review some of the challenging aspects of medical practice that serve to heighten our appreciation of the value friendship has for physicians. While applications to medical school show that plenty of young people continue to see medicine as an attractive career, enthusiasm over that attraction is usually balanced by a certain sobriety, and for good reasons. Medicine remains a highly demanding profession. Some of its demands are inherent to a profession that calls us to come close to the weak, distressed, fearful, sick, injured, and dying. This kind of care requires us to be present with others in their suffering. Now, to these burdens of the patient's suffering, we must add the physician's existential struggle with our own human condition, as medical practice brings us face to face with our own finitude and fallibility, which can manifest professionally as stress, frustration, exhaustion, and self-doubt. And to the burdens of patient suffering and physician existential struggles, we can add also the administrative burdens of insurance requirements, electronic health records, too little time with patients, fear of malpractice, and constraints on professional autonomy. Given these burdensome realities, it's not surprising to learn that the latest physician survey in 2018 suggests that almost 80% of practicing physicians in America feel burnt out sometimes, often, or always, And while it's encouraging that about 3/4 of physicians still find medicine rewarding, about half of them would not recommend medicine as a career for their children. Perhaps I should add that my daughter is a first-year medical student right now. I think you will agree that these realities just mentioned are sufficiently sobering to more than justify the claim that physicians need friendship within the profession to have the kind of support that can help them endure and perhaps even flourish. But I would like to suggest that there is yet one more source of trouble for physicians that is even more burdensome, in a foundational sort of way, than the burdens that arise from patient suffering, existential struggling, or administrative hassling. This further source of trouble brings us back to the soul of medicine, the beliefs, values, principles, and virtues that define the heart of professionalism and motivate the heart of the professional. The source of this trouble arises from differences in ethics, and more deeply still, differences in the anthropology and metaphysics that underlie ethics. In contrast to a traditional framework established through a synthesis of Hippocratic, Jewish, and Christian presuppositions and commitments, the reigning ethos in contemporary medical practice and education is buttressed by a metaphysics that is largely secular and materialist, by an ethics that is largely individualist and subjective, and by an approach to policy that seems routinely pragmatic, often expedient, and ambivalently speaks on the one hand of patient-centered care, while striving on the other for population health, cost-reducing efficiencies, and profit margins. Moreover, the traditional scope of medicine, curing, restoring, comforting, is being expanded by practices that use technology and authority to manage a growing range of psychological, social, and spiritual problems, and by practices that may seek to so-called enhance human capacities beyond their natural created potential. As Leon Cass has put it, we have welcomed in a medicine of means rather than ends, so that technology is increasingly available for the asking, independent of an objective concept of health that keeps biotechnology tethered to created reality, and an ethics of virtue that is tied to a genuine vision of human flourishing. This reigning ethos prioritizes a radical view of individual autonomy that increasingly encourages physicians and patients to see healthcare as a means to satisfy individual preferences based on a subjective sense of individual well-being, rather than as a clinical science defined by objective biostatistical standards. This ethos poses ethical and metaphysical challenges. One might realistically call them threats that are categorically more serious than the burdens of patient suffering, physician struggles, or administrative bureaucracy. More serious because they threaten to undermine the moral integrity needed to mount a genuine response to these other burdens. These threats to integrity form the basis of my concern for the intensified need for friendship among physicians. It is a concern bolstered by the various ways in which professional organizations and government bodies can and do impose expectations on physicians that create moral dissonance that occasions the need for conscientious practice. The experience of this dissonance reflects the extent to which the medical profession lacks a robust internal moral solidarity, a solidarity that in earlier times would have supplied physicians with enough like-minded companions to work with and rely on based on the sustaining power of a shared concept of health within a broadly shared framework of ethics. Instead, many physicians today who are trying to practice with integrity can feel isolated or alienated, or they may think there is no choice but to conform to the reigning ethos by compartmentalizing their convictions to avoid the unpleasantness of friction or the cost of negative repercussions. The lack of moral solidarity in the medical profession reflects the fact that the moral presuppositions underlying medical ethics are contested, as can be seen in disagreements about health itself, what constitutes a harm, quality of life, dignity, who counts as a person, autonomy, justice, suffering,
and death. The professional moral landscape is fragmented, but this does not necessarily mean that moral pluralism is tolerated. Indeed, through the policies of academic, professional, institutional, and government bodies, there is a dominant ethical expectation that if a medical practice is legal, available, endorsed by professional organizations, and desired by a patient, then it should be provided or at least facilitated by a physician whenever a patient requests it. For physicians whose consciences have been formed by a robust respect for life and by a concept of health based on biostatistical norms and Christian anthropology, these are trying times. So physicians need friendship. We need the help and encouragement of like-minded fellow travelers who we are blessed to call friends. Friends who can confide in each other, bear each other's burdens, and encourage each other to discern clearly and act wisely and courageously when facing the moral and spiritual challenges that arise in patient care when manifestations of moral pluralism create tension or frank conflict. The fellowship of such friendship provides a refuge of moral solidarity that the broader profession of medicine does not have. What are some of the essential benefits of such friendship, especially for Christian physicians? And I'll mention 6 now. First and foremost, friendship brings the encouragement that comes from seeing the same truth and desiring to live out its implications. As C.S. Lewis points out, friendship is more than mere companionship. For friendship arises when 2 or more companions, quote, discover that they have in common some insight or interest or even taste which the others do not share and which, till that moment, each believed to be his own unique treasure or burden. They discover a common quest or shared vision, and at that moment, friendship is born. Quoting Emerson, Lewis notes that in this kind of love, do you love me means do you see the same truth, or at least do you care about the same truth? As already indicated, medical practice requires a vision of what health is and what health care should be. This is a question of what is true and good. And when the answer to this question is shared among physicians, the foundation of professional friendship is set. Second, Oliver O'Donovan notes that friends help us realize our calling by sharing in our tasks either directly as working partners or supportively through reflection and, we may add, fellowship and prayer. One of the key contributions of Christian medical organizations is to provide opportunities for reflection and fellowship that allow Christian physicians to remind each other of the true nature of their calling and to encourage each other to remain faithful in that calling. Third, friendship strengthens us to persevere amidst opposition and even to resist. As Lewis observes, the strength between friends explains why communities or authorities may dislike or distrust friendship. Quote, every real friendship, Lewis explains, is a sort of secession, even rebellion. Each set of friends, therefore, is a pocket of potential resistance. There are many concerned physicians today who are gratefully aware of this strength and employ it by joining efforts to be salt and light by criticizing and resisting practices that run counter to human flourishing and by demonstrating the better way by their own clinical practices. Fourth, friendship, unlike clubbiness, makes us ready to include others to enlarge the circle of friends. O'Donovan reminds us that friendship, unlike marriage, is not an exclusive relationship, but part of a series of concentric circles that allows of greater or lesser proximity. And the welcome sign into these circles is manifested by friendliness to those outside the circle, which prevents friendships from becoming cliques and keeps us alert to opportunities for new friendships. In medicine, the importance of gathering like-minded physicians together is very clear to me, whether at the local, regional, national, or international levels. And this like-mindedness may, at a minimum, represent a fellowship of co-belligerency, and at a maximum, a fellowship of faith. Fifth, friendship reminds us of our basic neediness as human beings. Gilbert Meilander, who I'm very pleased to see will be speaking at this conference, draws from Augustine to describe how the reciprocal nature of the love of friendship demonstrates the truth that human beings, if we are to flourish, need to not only give, but also receive love. And when we admit our need for this kind of mutual love, we are a step further in admitting our need for God and His love. I think it is fair to say that physicians tend to value independence as a character trait. And physicians may need to be reminded that we are not and are not meant to be lone rangers. Our flourishing is to be found in our relationship with God and through our loving, dialogical, and interdependent relationships with each other. Sixth, friendship is a school of virtue in which we grow in our love of neighbor. Listening again to Mailander on Augustine, we are encouraged to appreciate friendship deeply by seeing its connection to Christian love. Mailander notes how Augustine fashioned this connection because he understood caritas as, quote, a love which draws the self toward God and loves the friend in God. Seen this way, friendship is a beginning of a progression that starts with a love that is particular and preferential, but one that also functions as a sign of and call toward a love more universal in scope. For Augustine, friendship is one instance of the dynamism of love in which any particular love, taken seriously, will draw us beyond its own particularity toward the one who is love itself. It's sad to think how many physicians may be so burnt out by the demands of medical practice that they feel they don't have the time or emotional strength to attend to their patients as persons, as opposed to mere bodies, even if doing so would only entail something as basic as taking time to listen. But it's encouraging to think that when physicians are nourished and buoyed by Christian friendship, the inner dynamic of that reciprocal love bears further and larger fruit by strengthening a broader Christian love that is unconditional and therefore perfectly arranged for the care of patients who occupy the receiving end of the asymmetric structure of the patient-physician relationship. So in conclusion, friendship brings many gifts. In it, we delight in the same truth. By it, we gain help to realize our calling and find added strength to persevere and resist. Into it, we welcome others. And through it, we are reminded of our fundamental neediness before God and by His grace nurtured in virtue and sanctification. These are gifts that physicians need in the midst of a profession that does not provide a professional basis for deeper moral solidarity or identity. This is why physicians need friendship, and why Christian physicians need Christian friendship to keep company with fellow travelers who are committed to a deep respect for human life, a shared concept of health, and a high sense of calling to love one's neighbor in the person of each and every patient. Thank you very much.
Next, we'll have Dr. Bryan Pilkington from Seton University. He'll be speaking about unbefriended patients, why friendship may not be the answer.
Thank you. Thanks everyone for coming. I know there are a million sessions at the same time, so all of us appreciate you being here. I'm going to read part of a paper. It's a section of a broader paper, so this presentation will be unsatisfying in at least two ways. One, I'm not going to offer a rich account of friendship that happens elsewhere in the paper. And two, I'll be engaging the practice of clinical ethics consultation, and I'm not going to offer a rich account of that either. So, apologies. Patients who need but lack surrogate decision makers are sometimes referred to as unbefriended patients. Without an advanced care directive, healthcare proxy, or another mechanism to aid in ascertaining a patient's values, a patient may be left without someone to support the realization of those values. Unbefriended patients raise a challenge for clinical ethics consultation, precisely because their values are unknown. This challenge is not properly understood ethical in nature, but rather epistemological. Were the patient's values and the situation-specific wishes known, the challenge dissipates. At least it dissipates within the context of contemporary bioethics. To address the epistemological challenge, I argue, seemingly paradoxically, that what unbefriended patients need is not a friend, but a change within clinical ethics consultation, from relation-focused to information-building decision-making. Relation-focused decision-making describes practices which seek out decision-makers, that is, other agents, as determiners of what is best for a patient who cannot speak for herself. Surrogate decision-makers are the ideal response to this challenge for advocates of this approach because they can speak for the patient. A surrogate decision-maker is able to articulate the values of a patient and apply them to the current situation which is facing the patient. Information building describes practices which seek information about a patient in order to have an accounting of what would be wanted for her, from her, that is, an articulation of her values. The information building approach aims to build a picture of that patient as a person that is sufficiently rich to allow for the application of her values to the current situation. I argue that the information building approach to decision making is superior, at least in light of certain current contextual constraints, because it successfully addresses the epistemological challenge in cases of unbefriended patients. These challenging situations offer few resources for clinical ethics consultants due to the limited and limiting nature of the values-focused framework of contemporary bioethics, which governs clinical ethics consultation. Before moving forward, one point on language should be noted. I mean nothing offensive by the phrase unbefriended patient. Other phrases employed to describe such patients have become more popular of late. For example, patients alone or unrepresented patients. I don't have an issue with such terms. In fact, it may very well be the case that the patient has a friend or has many friends, but due to the nature of her injury and the manner in which she presented to the healthcare team or the hospital, those friends are simply not known to those who are looking after her. That said, I believe that thinking about friendship is helpful in clarifying the issues associated with persons in these situations, so I'll just use unbefriended. I became interested in questions surrounding unbefriended patients through conversations with clinical ethics consultants and some challenging puzzles involving legal responses to their situations. One such case is clearly described in a recent piece by Lauren Flicker in the Journal of Clinical Ethics. And to quote Flicker, quote, "The case involves a dying, incapacitated octogenarian who had friends who were willing to share her values but not make decisions on her behalf. These circumstances put the patient in a unique position of being legally considered a patient alone, but who was ethically like a patient with surrogates." What were those circumstances, you might wonder? To quote Flicker again, Ms. E, an 83-year-old woman suffering from an intracranial bleed, had been unconscious and on a ventilator in our hospital for more than a week. The next step was a tracheostomy and a peg tube and discharged to a nursing home. Miss E had lived alone in the community and had no known family. She did have close friends who were visiting and speaking with the clinical team, but neither friend was willing to act as a surrogate decision maker. Spoiler alert if you're interested in reading the article, Flicker solves the legal case, and the laws in the state in which this occurred are actually changing. So it ends up not being a legal problem. However, that's not really what I'm interested in. Cases like this, cases at the fringes of legal and moral categories, invite us to rethink those categories, not merely to solve these interesting puzzles. A common response to unbefriended patients is to seek out a surrogate decision maker, or someone who will speak for the patient. And if one is not found, the state sometimes comes in through legal guardianship. Another response to persons in such situations is to search for a clear articulation of the person's wishes, for example, an advance directive of some sort. The latter would be part of properly practicing the information building approach. The former, as I have mentioned, is a paradigmatic example of relation-focused decision-making. It is true that these responses play similar roles in the clinical ethics consultation experience, at least my familiarity with how it's practiced. That is, they afford the clinical ethics consultant with information about the patient's values and someone to engage in thinking about what is best for the patient. However, that is where the similarities cease, and it would be of benefit for clinical ethics consultants to pay careful attention to the differences and not think that both approaches are of equal value. The surrogate decision maker, or a friend, is not merely, even at best, a reliable belief-forming mechanism about the patient's preferences. She is the patient's agent, and that makes a difference. One approach offers that patient another agent to speak on her behalf, a decision maker. The other approach affords the clinical ethics consultant with information about the patient from which to specify what she would have or might have done in the situation that is currently facing her. The difference is highlighted well in the case Flicker describes. It is stated that the patient's values were known. Her friend shared this information, painting a picture of the patient and of what her preferences would be in light of what they knew about her. But there was no one to decide for her. She lacked, interestingly enough, given the current terminological trends, a friend. A friend is different from merely someone who reports a patient's wishes. And I'll ultimately conclude at the end that in light of this, clinical ethics consultation ought to move away from the relation-focused model of seeking out surrogate decision makers and instead embrace the information-building model. That model supports what was prudently done in the case described. The clinical ethics consultants should don their detective caps, search out information about the patient, and paint a picture of the patient from which a decision about the patient's wishes could be reached. To further illustrate the difference, contrast the case of Miss E with a hypothetical one. Suppose, God forbid, that I were to find myself in a situation where decisions needed to be made about my care, but I were not able to do so. In such a case, I am fortunate to have a friend, my wife, who knows me well, who understands the narrative of my life, at least as well as I do, and could and would make the relevant decisions. This is neither to say that such situations would not be challenging, nor that a good clinical ethics consultant couldn't be helpful. I'm sure the situation would be difficult, and I'm sure that good clinical ethics consultants would be of aid. But the discussions, I believe, would be different. My wife in this case is a proper surrogate decision maker. She is a friend, another self. In fact, this brings to mind the dedication in Gil Mylander, who's already been mentioned, in his little book on friendship, which I've been rereading recently. And the dedication, I think, is from Sirach, and it goes, "A friend or companion is always welcome, but better still to be husband and wife." Now, one way in which these discussions differ, that is, discussions involving a friend and discussions involving persons from whom the clinical ethics consultant seeks information, is that the central question to be asked is different. If, to continue this unfortunate for me hypothetical situation, if, say, Dr. Kaldjian were overseeing my care, he might ask my wife what I would want, but he might also work with her to ascertain what is best for me. What is best for Bryan is a question that he could ask and which she could answer. However, it is not a question that could be answered in the case of an unbefriended patient. It is not the question that clinical ethics consultants are focused on asking, especially as the practice exists governed by the norms of contemporary bioethics. There, the question is, and I think the only question is, what would Bryan want? This should not be surprising to those who have been engaged in the moves of contemporary bioethics. The resources of dominant approaches in bioethics force us to conceive of persons as lists of values. This metaphysical accounting of persons shapes the kind of inquiry into the situations of unbefriended patients. Ascertain their values and apply them. More is not needed because persons merely are lists of values. Now, this metaphysical picture surely makes things easier and cleaner. The messiness and complication of human life is bracketed, but so is the nuance, the deep and rich understanding of life and life's journeys. What is lost, in a word, is the person. If my description of contemporary bioethics is correct, and I think we see this in lots of places in contemporary bioethics, from principlist focuses on autonomy to the adjudication of disagreements over conscience in a variety of areas. So if I'm right about this, then in some ways the employment of surrogate decision makers is an odd choice in the first place for clinical ethics consultation under contemporary bioethics. What is often said of such persons is that they speak for the patient. But is the clinical ethics consultant informed by contemporary bioethics looking for this? No. I think she's actually looking for someone to list and apply the values of a patient. She is not seeking a practical reasoner aiming at the good of another, that is, a friend. There are at least two objections to my argument thus far. First, that the question that I have claimed is central to clinical ethics consultation practice, what would a patient want, is not in fact the question that should be asked by an enlightened bioethicist. Rather, she would ask, what are the patient's preferences? One can appreciate the linguistic differences here. A patient might want $1 million. She might want not to be in a particular disease state. She might want for Michigan not to have done what they did to us 2 weekends ago. But these aren't available, right? Preferences are. In response, the question, what would the patient want, seems, anecdotally, to be asked a good deal in hospital settings. This is because that change in terminology does not get at the central difference between the questions I originally considered. So if you want to use that terminology, that's fine, but it's missing something. The preference question differs in the same way that the want question did from the real question we should be asking, right? Neither allows us to ask what is best for the patient. A second objection comes from an even more enlightened bioethicist, who might chastise me for relying on an account of contemporary bioethics rooted only in principlism, but failing to take up more recent trends, for example, in narrative bioethics. Following this, she might suggest that the clinical ethics consultant could adequately ascertain the values of the patient and apply them in the current situation. The idea being that the clinical ethics consultant can continue to operate in their usual fashion, surrogates for unbefriended patients, and if they can be found, or some sleuthing to discover and apply their values as a backup. However, thinking of human beings as storytelling animals is not sufficient to assuage my concerns here, nor to argue that contemporary bioethics possesses the conceptual resources to support surrogate decision-making for unbefriended patients. Consider, appropriate to this conference, one description of the importance of narrative in lives and in understanding human life from Professor McIntyre. He says, quote, "Man is in his actions and practice as well as in his fictions essentially a storytelling animal. He is not essentially, but becomes through history, a teller of stories that aspire to truth. But the key question for men is not about their authorship. I can only ask the questions, what am I to do, if I can ask the prior question, of what stories do I find myself a part?" This account of human beings as storytellers and of the importance of understanding narrative for understanding them differs in at least one crucial way from the narrative offered in our first case, that of friends describing a person and guessing what she would want from those descriptions. There is no consideration of the stories of which she is a part. Her story is pulled together from the brief recounting of experiences. It's her story, sure, but in a more narrow sense than the kind of story that Professor McIntyre might ask of us if thinking about this situation. So even if contemporary bioethics embraces narrative, it is not clear that it can do so in a way that is wide enough to really do all that it needs to do. It can't paint a full picture of the person, which would be helpful if you want to know what a person might decide or what's best for the person. And that sort of picture is the picture a true friend could offer. What I have argued today is that the conceptual resources of contemporary bioethics, which govern clinical ethics consultation practices, leave clinical ethics consultants in a challenging situation with respect to unbefriended patients. This is because they often operate with what I have called a relation-focused model, looking for a surrogate decision maker to speak on behalf of a patient. However, given the limited and limiting resources of dominant strands of thought in contemporary bioethics, this model cannot be supported. In light of this, I've argued that clinical ethics consultants should abandon the relation-focused model and instead fully embrace an information-building model. That is, they should respond to the actual set of questions they have, which are not ethical in nature, but epistemological. What would the patient want? The surrogate is not the answer to those questions. Clinical ethics consultants are not seeking a practical reasoner, a friend for the unbefriended, but at most an applier of wishes. And clinical ethics consultants are just as good appliers as any, maybe better, and should fully embrace the virtues of good investigation and the information gathering model. There are exceptions to this suggestion, of course. To those of us who are fortunate enough to have a friend, or a few friends, a person or persons who can ask the, "Is this good for the patient?" question. We would be better served by a friend. Unfortunately, this is not the case for the unbefriended, and if you accept my claim that a friend needs to be able to ask such a question, we might wonder, with a hint of anxiety, about how many more patients than those labeled as such are truly unbefriended. Thank you.
Now let's welcome our third presenters, Dr. Andrea Mariani and Dr. Nadeem Abu-Rustum. Dr. Mariani is from Mayo Clinic, Rochester. Dr. Abu-Rustum is from Memorial Sloan Kettering. The title of their presentation is "What Can Withstand the Test of Time? Friendship in Science and Medicine."
Thank you. Thanks, everyone. So first of all, I'm really grateful to be here. Thank you. And I'm grateful in particular to Paolo that is a friend of mine and he told me about this event. And so thank you for that. And then I'm grateful to be here with Nadeem that we can speak about our story of friendship. So what can withstand the test of time of friendship in science and medicine? The aim is really to describe the impact of friendship in our work as doctors, surgeons and scientists, and how friendship has helped us to do a science for the patient and sustain a human gaze on the sick person in a way that withstand the test of time. So this is me and this is Nadeem and this is Mayo Clinic. So I work at Mayo Clinic in Rochester, Minnesota. I do surgery, cancer surgery. I do a lot of robotic surgery. So this is why I show myself sitting at the robot. Nadeem.
Yeah, I'm Nadeem Abu-Rustum. I'm also a GYN oncologist like Andrea. We do surgery for female cancers. I work at Memorial Sloan Kettering. It's a big cancer hospital in New York City, in Manhattan on the Upper East Side, and I've worked there for 20 years.
Thank you. And so the first thing that we are asking is, why did we become doctors and move to the US? And like everything starts from a desire. No, a desire, because like many things that we do in life, we desire to do something. And I wanted to do something good. I wanted to be useful to people. I wanted to help people. And so I decided to go into medical school. And these are Italy, my first two mentors, Luigi and Dario, that are the two people that helped me to put the first stitches and that allow me to start to do the surgical specialty. And then at a certain point, I realized that staying in Italy, I couldn't really practice medicine in the way that I wanted. And I wanted to practice medicine in a way that was good. It was good for the patient. It's a form of charity, a form of love to do your job well for the person. And so I decided to come to the United States. And so I came to Mayo Clinic, Rochester, Minnesota. Unfortunately, Rochester, Minnesota. At that time, I didn't have the money to buy a car. And so this is the bicycle. And Nadeem.
So I grew up in the Mediterranean. I grew up in Lebanon. It's on the Eastern Mediterranean. So I did not know Andrea growing up. He was in the Roman Empire, and I was in Lebanon. I grew up in the north of Lebanon in a small town called Amyoun. My father was a physician. He passed away about 20 years ago now. Always was interested in science, always wanted to help people and always wanted to teach. So this combination of deep interest in science, wanting to give and take care of people and also to teach really drove me into medicine. Went to medical school in Lebanon at the American University in Beirut. And then at the end of my medical school, Lebanon was going through a 25-year turmoil of a huge civil war. Decided to move, as many young people at that time moved out and went to the United States seeking opportunities. Unfortunately, the country is beautiful, but still suffers from a lot of turmoil. So the move that I did 30 years ago continues to happen nowadays. And then as I lived in the United States and went through residency, fellowship, and work, met Andrea through our academic conferences and congresses and crossed paths, and we'll tell you more about how we became more friends and what really drove us more into this deep friendship that we had. But one very important message to me is that deep friendship can happen later in life. I always thought I would have my best friends when I grew up, like the people that I went to in high school or even younger. But the reality is you can really form very deep friendships when you're 40 and when you're 50, which is really wonderful. And that's what happened to us.
Thank you, Nadeem. And this is, at the beginning, I arrived at Mayo Clinic and I had the possibility to have a mentor. This is Dr. Poderax, my mentor. And I remember he told me, with surgery, you can cure one patient at a time. With research, you can cure many patients at this time. And so I started to be interested also in research. So to continue to do surgery and to be interested also in research. And so we started to do a lot of things together. I specialized in endometrial uterine cancer, the same as Nadeem, and I started to publish. We did many papers together, and during that time, it was again 1996, and then the beginning, and so I started, and I found myself starting to go around and at conferences to speak about uterine cancer, and at a certain point you start really to go in different countries and speak about this. So it became really an important part of my life. But then as you all know, life puts us on trial. So it started from a desire, no? But then I say also the most generous and grateful heart gets tired, may get numb. The heart itself is not enough. All the physicians and scientists, especially those who have worked for many years, know well that this is possible. Generosity does not remain faithful. What then can withstand the test of time? What allows us to remain loyal to the initial desire that moved us to become doctors and scientists? And so and this is what happened. I was going around the world speaking about uterine cancer, and May 2013, I'm in Japan. And I'm doing a conference, I'm doing a debate, and I'm speaking about lymphadenectomy, and I will tell you what it is in endometrial cancer. And during that conference, there is this guy, Nadeem Abu-Rustum, from the competition, the Memorial Sloan Kettering Cancer Center. And so this is Mayo, this is Memorial, and we were doing a debate, and I was saying endometrial cancer needs a lymphadenectomy. And what is a lymphadenectomy? A lymphadenectomy is that the cancer goes to the lymph nodes, and so how do we understand that the cancer has gone to the lymph nodes? We remove all the lymph nodes. And so it's a big, long operation that can give complication, etc. And it was at that time, 2013. And Nadeem, this guy, he was speaking about something new that I really didn't like a lot. And it was sentinel lymph nodes. He was saying, if you inject the cervix of the uterus, you can find the right node. And I was saying, why inject the cervix? It's the uterine corpus. There is the cancer, so it doesn't make sense. So at the beginning, I didn't really believe that Nadeem was right. But then we started to, at that time in Japan, we started to spend some time together. And we realized that we wanted the same thing. We really wanted to know the truth, what was right. And so what we did, after some reluctance a little bit, we decided to share the data of the two institutions. So Mayo Clinic, we were doing this big operation, and the Memorial, they have been doing for some time the sentinel nodes. And we said we just give the data to the statistician so that we are not biased, and we see what happens. And at the end, Nadeem was right. So the sentinel node were finding as many patients with positive cancer with a much smaller operation. And then we publish some paper together. We help to write some guidelines. We are doing a clinical trial together. And at a certain point, in my institution, it was not easy at the beginning to bring this to my institution, because it was what we have been doing for so many years, and we have even become famous with that. And so it was not something that it was easy. But I let Nadeem tell his version of the story of this part, and then we make some considerations.
So Andrea is very humble. What you don't know about him is that he remains and has been for decades the biggest name associated with anything that has to do with surgery of uterus cancer. So the name Andrea Mariani over the last 20 years is associated with everything that we talk about, and he developed all the Mayo Clinic criteria. So he's a very humble man. But the beauty about this story and this deep friendship that we've had is that there was no ego. It was not about Andrea. It was not about me, I. We did not care whose name was on the paper. In fact, we wanted our fellows and trainees and partners to be the lead authors, and we had nothing to prove. We were just interested in the truth and really doing the right thing. So putting the egos aside was a huge impetus to the success of this relationship. Andrea also, to me, represents the ultimate in courage, which is a huge sign of leadership. You need courage to face all the odds, and he did take a huge risk of not being popular in his own community and in his own university, which is not easy to really take the risk of being unpopular among your friends. But because it was not about the brand name, and it was not about commercialism or selling a product, it was just trying purely to find what is the truth and how can we find it and how can we really learn from it and move with it. So he did take a risk. And we say in medicine, synergy is when you add two things, you get a profound effect. So this friendship really created a huge synergy for both of our messages. So if I had continued to try to push my message, this would have been my curve of progress. But with our teaming together and working as friends, this became the curve. So the energy of two friends who were debating and who were actually not clear on completely being aligned really made it much more powerful for me to say the message and for him to also help push this message. And we are just starting. So although we've made progress in our own institutions and around the communities of cancer centers, but we are just starting, and we say this all the time, we still have a lot of work to do. And having a friend and a colleague who really deeply believes in this message of it's not about us and it's not the ego and it's not me, I, it just really helps a lot to move this forward. So thank you for the ability for us to do this beautiful work together.
Yeah, but Nadeem, but why did you? No, because the agreement was that he was speaking about him, not about me. So, but why did you decide to trust and to say? Why did you decide to say, okay, let's put the data out there? Because at the beginning we didn't know where the data were going, and why did you decide to start this journey?
You want to know the truth. I mean, who doesn't want to really know the truth? Do we want to just keep continuing living in what we heard or what we read in books or what we learned? You really want to try to get to the absolute simple reality of things that we work with every day. So, and I think we share this concept, is we just want to really know the absolute truth of what we deal with on a daily basis. And it was, the simplest thing was to really break down all the walls and take down all the silos and the boundaries and say, here's what we have and here's what you have, and let someone else look into it and just share the results and let's learn from it and move forward. So, and I have to say, I have to give him a lot of credit, because I did fight my battles locally where I was, but I think he did have to do that a lot more than I did. And that's, a lot of credit goes to him. And his son is here, and I'm so glad. I wish my son was here. So his son Pietro is here. So that's a huge thing that your dad did, and it's a huge teaching point for young people.
But what would you tell a young person? You spoke about discovering friendship in a certain way at a later time. Why do you say that?
So, I think a lot of us at a young point in life, and I've been through that, you think you have this commando phase that you can do everything, you're invincible, you don't need anybody, and you lose faith in a lot of things. And I'm sure a lot of us have gone through this phase where you think you really don't need anybody, and you almost get to the point of losing faith and not needing anything. You can do everything. But that's a transition, probably a natural transition that we all go through. But limit that to the minimum as much as you can, because the reality is, I think you will be able to go through life and the challenges, especially now with everything that goes around us, much better with friends and strong friendships. And I wish I met Andrea in 1990, the day I landed in New York City, but I didn't. So, and I wish our friendship had gone much longer than we have. But again, I would say, go out and try to find your friends. If you're in medicine or in healthcare, it will make life much easier. And we've heard from the previous two speakers of how difficult and challenging it can be. So we do need these deep friendships, not only for science and research, but for patient care and for being able to balance life and work and go back to your children, go back to your wife or spouse, and be there and give the same amount of energy that you give every day when you're in the hospital or when you're doing surgery.
So thank you, Nadeem. We just a final comment. We believe that our friendship has helped us to be better doctors, scientists, and human beings. Our story speaks about a friendship that has helped science to remain attached to the truth in a way that withstands the test of time. It is more effective and convenient for everyone to follow this path. What moved us is a love for the truth and the recognition of the importance of a friendship like something new that we were discovering. In our life and works, we have experienced that desire and gratitude are not enough. The environment is not enough. Also, the face of the patient is not always enough. it is important that the human being is not alone. In order to continue to sustain a gaze of love on the patient and an attachment to the truth in science, we need a friend, a place on friendship. Thank you.
Thank you for these wonderful presentations. We have about 15 minutes. Who would like to ask the first question?
Thanks to all of you. I have a question for Dr. Mariani and Dr. Abu-Rustum. You talked about the importance of coming to alignment on the truth about how to handle the sentinel nodes. How much more difficult would it have been if you couldn't come to that alignment? And what I mean by that is if you think about something like abortion, where you might be developing a friendship, but you may not be able to reconcile your own ideas, how would your friendship path have been different?
I think it would have been much more difficult. I think the example that you bring is very difficult and challenging. What we try to do is to basically erase all of our biases and all of our prejudice when we said, let's look at this problem in a very pure, simplistic way. What is the question that we're asking, and what would be the simplest and most natural way to get to the answer? We were both looking at something that is controversial, but not as deeply controversial as the example that you raised, which creates a much more difficult level of a discussion. But I think friendship and the ability to think through this can even allow us to face much more difficult medical challenges similar to what you raised. Andrea?
No, to me, really, friendship is the possibility. The friend is the one who puts you in front of reality for what it is, and so and it puts you also in front of your heart and what your heart desires. And so the friend is the person who helps you be true with your heart and be true with reality. And then at a certain point, this is part of the journey. And so it's not that we need to agree in every single thing. Sometimes even during meetings, Nadeem thinks more. So for example, I overemphasize the tumor diameter in uterine cancer. You see he's smiling because he doesn't like that. So what I say is that we don't always agree on everything. There are certain things that we may disagree, that we can see them from a different point of view, but I think his presence helps me not to be too biased in one way, and for him it will be the same.
It's like in the Mediterranean, in any negotiation, you have to leave something on the table. So I got to leave him something on.
This is for Lauris and Bryan. I wonder if one of the sort of central challenges to which you're both pointing is that the morality and even the moral solidarity that's guiding medicine is really become very non-Christian, very anti-Christian in many ways, or at least being framed outside of any kind of Christian framework. And in some ways, it's too easy to point to things like profit margins. And here what I'm thinking about is the Canadian healthcare system and its immense adoption of active euthanasia. The data on how quickly active euthanasia has been adopted there is just remarkable. And it's being driven by the bioethicists, right? So the moral framework that is being driven by the people who are supposed to be bioethicists. And of course, they are thinking of this totally outside of any Christian framework. So any thoughts? Because it seems like that's part of what's underlying the worries you raised.
No, I completely agree with what you're saying, Mark, and I think you've answered your own question very, very effectively, and I thank you for that. I would say it's very interesting to think about the contrast between what you all were just saying in terms of setting aside prejudices. By contrast, when you think about something like faith-seeking understanding, we need to start with commitments, what I call foundational beliefs and values, upon which you have a foundation to do and think and practice anything, right? We have to have our starting points, and the roots go all the way down. And on the question of assisted suicide and the candidate frank euthanasia that has swept the land since 2016, since it was approved by their Supreme Court, it is remarkable how, when you think about in healthcare and medicine, this basic act and the intention of acting to basically end the life of a patient, choose which word you will, kill, hasten, whatever it is, and set aside the rhetorical language that talks about medical assistance in dying, which is, is that much rhetoric and euphemism. And so when you ask yourself, okay, what does it take for a physician to have a commitment on this question of whether they would ever intend to do such a thing? And your answer in terms of the Western culture is certainly the Christian Jewish traditions have put a stop on that for all this time in terms of setting the expectation, and that has certainly changed. And so now one of the things to look out for, in fact, I was just speaking to Richard Dorflinger, who's at this meeting, and the tremendous work he has been a part of for so many years on these vexed questions. It's interesting to listen to different people even talk about palliative care and whether in that, under the umbrella of palliative care, assisted suicide and euthanasia are seen as part of a continuum. And sometimes I'll literally, my radar, of course, is out for this, but when I'm reading a journal article, I'm thinking of one article that had a name, Timothy Quill. Many of you will recognize that name. The figure had exactly all these different possibilities as one continuum. Whereas for some of us, if we ever put two figures or tables together, we wouldn't even put those last two options in the same box, right? Because we don't think that's part of palliative care. We think that is something categorically different. But the culture we're in does not believe so.
Thanks, Mark. It's a great question. So one of the features that was very interesting to me was your description that bioethicists are pushing this. And that makes sense from the outside, not being Canadian nor doing bioethics there, because the kinds of questions that bioethicists ask, if you buy what I was saying in the talk, is something like, well, what would the patient want, right? You just want to figure that out. It's not the kind of question like, well, what would be best for the patient? And I mean, hearing wonderful doctors speak on this, I don't see as a non-clinician a good physician being able to say, yes, it is best for the patient to kill the patient. That just seems too far. So, and it may be that once you start asking those, what is best for the patient, then you start getting into deeper existential questions, which we need richer traditions and bigger frameworks for.
I'm not a physician. I've never been in an AMA meeting or any sort of professional physician meeting. Is there an opportunity for physicians like you to gather together and to talk about your concerns, say at a professional meeting?
Well, there is, and in fact, if you're interested in that question, if you don't know Richard Dorflinger, I encourage you to meet him, and you can hear him tell many stories. But the big event over the last year or so was that the AMA reaffirmed its opposition to physician-assisted suicide, which I think many people who are concerned about this question in this country were not expecting that necessarily to be the outcome. And not only was it reaffirmed, it was robustly reaffirmed. Right? And it even involved, I'm told, even the participation of a group of medical students who added their voice to this, as well as plenty of practicing physicians. So yes, there are opportunities, usually when a decision or a position statement has to be dealt with. Right? How much otherwise is there discussion about the more vexed questions within professional circles? I actually say to my medical students at the University of Iowa that one of the reasons why I have discussions about difficult things in large groups with the whole class is to say that actually you don't get many opportunities in professional life to actually learn to speak candidly, respectfully, but courageously about the positions you believe are best for all of us.
When I was little, my parents used to tell me when I was going to the doctor or to the dentist, like, he's your friend. It's something that, because, you go to the doctor and you're alone, or maybe your mother there to see what's happening. But it is like, it is, you trust in someone that even that knows he's trying to help you, even if you even if you don't know the person. And that's something that encourages to have this like faith. I think when you're a patient, you have faith in your doctor. You have like you have the expectation that he's going to provide you with the answers that you need. So I think it's challenging. Maybe it's good to create this connection with your patient. I think sometimes also very difficult. I was just wondering, what is your approach? What do you think is like how do you treat each patient like a little like a child that you want to help, or somehow it's better professionally to set I don't know, like put expectations, tell clearly what is going to be like the outcome or certain things. I don't know. I was just wondering that. What do you think?
Just the way that you speak make me feel a kind of very, very humble, because it's true that patients come to us all the time feeling obviously that they are unique, and that and it's the same because I've been a patient as well. And so this is why, for me, it's important to have friends, to have people. So, for example, I work with a nurse. Her name is Jess. And she comes with me to see every patient, because we see patient and then she put the orders in, etc., and she helps. I tell Jess at the end of the encounter with the patient, is there something more that, so I ask Jess to remind me that it's important for me to be reminded all the time. If I'm seeing 20 patients in one morning, I need to be reminded that this patient is unique. And sometimes, yeah, it's there, it just clicks. Sometimes it's not. And so Jess, sometimes she tell me, oh, Dr. Mariani, you forgot about this. And then, oh, I have a reminder. So this is the beauty of friendship. But thank you for reminding us as physicians how much patient, and you know, we are surgeons, patients put their body in our hands. It's big.
Can I just, if I would encourage you, if you've never, have you heard about the ethical and religious directives that govern Catholic healthcare in this country? It's a beautiful document, at least I believe. And maybe, Peg, you can remind me where, somewhere in that robust document, there's a meditation on the parable of the Good Samaritan. Which section is that?
It's in the beginning.
In the very beginning, because if you wanted to, as a Christian physician, in terms of my deepest motivation to care well for my patient and to hopefully gain their trust, etc., would basically being the second of the double love commands, to love God and to love my neighbor as myself. And remember, that was the question that prompted Jesus to tell the parable of the Good Samaritan, and it's a lovely meditation. Do you want to comment on that, Peg?
Well, there's just that's available online. You can get that online. It's a very good document to have in your pocket and look at every once in a while to guide your practice if you're in medicine. So, but it's readily available and well worth the meditation of reading each of the sections of it and the scriptural passages that go with each of the sections of it. I had a question for you, Lauris. Now that you led into me, you said that a robust moral solidarity in medicine requires its foundation in truth. Okay, and you hold that. And I teach medical students, and I'm finding that commitment to truth to be very difficult for them to take hold of. To look for evidence in regard to the judgments that they're making. And the example that I want to use is exactly the one you cited. That is the statement by the American Medical Association this past year on physician-assisted suicide. A very powerful movement coming out of the West, coming out of Oregon Health Sciences University, really pushed that question. And under the rubric of medical assistance in dying, they wanted physicians to be committed to that. Okay, and the American Medical Association said, we're going to study that, all right? And they set up a committee to do it for 2 years. The committee made its recommendations, and the Medical Association said, we're going to continue to oppose physician-assisted suicide. Why? Well, because of the evidence that was brought forth. And what's going on in Oregon? All that data is out there. What's going on in Oregon, the terrible things that are going on there. What's going on in Europe? But our young people as medical students, they either don't know about that data or they don't see it as evidence in support of the truth. And so what I'm seeing over time, and that group in Oregon is a very powerful group, and they're going to keep coming back and pushing and winnowing away at this moral authority committed to the truth. How do we instruct our young medical students that the evidence is important?
Yeah, I think part of it is just, it's like so much in life is, it's clear thinking about what we're talking about. And even the distinction, say, between law and policy on the one hand and ethics on the other. I've got a lot of sort of quick thought responses to that, which I won't go into right now, but maybe one thing that I would say is, I wonder how many students would have just such an immediate sense of the prerogative individuals in our society should have to basically do things that they want to do in their own way. Now, granted, one of the things that quickly I think they often fail to take seriously enough is the fact that the very moment a physician is involved, it's no longer just individual autonomy. And if you look at I'm sure one of the concerns that you do share from Oregon is that if you look at the number of patients who actually are referred to a psychiatrist, it's less than 5% over the total history of that program. And I find that incredible to think that less than 5% of all the patients who go to one doctor and say, I'm interested in this assisted suicide, that less than 5% would be seen by a primary care or other doctor as, well, maybe you really should talk to someone about the possibility of depression. And that simply tells me that the physicians they're encountering at the first step are physicians who are inclined towards seeing the validity of rational suicide, et cetera. So I think the question of the ethics, where some would call it expressive individualism, sort of runs the day. I think part of what you're asking, though, is do people care about the wider social implications? And I would say also the erosive effects on the medical profession. I think a lot of it is just a lack of a breadth of vision to actually take seriously the way the world works. And that's why it's very helpful that some of our colleagues have pointed out the work from Netherlands and Belgium to see where the slippery slope literally does lead. And is that something we want to support? So I think we just need to keep trying and keep being very friendly in our appeals to reason and to point out the logical connections between one thing and another.
We have one more question. You had your hand up on the right. Yeah, you were.
Well, it just leads right on to this, so it's fortunate that I asked the question. I mean, it's easy to kind of know what the truth is. You can find the truth by doing this randomized controlled trial that you guys are trying to do. And then the next question is, well, what that's an empirical, observational, scientific truth, and then linking that up with truths that escape any sort of scientific validity is something that we've kind of lost precisely because we've raised science to a kind of as the final arbiter of all things that could possibly be said to be true. So I was wondering if we could talk about how we get moral truth to line up with a kind of scientific truth. And I'd like to hear all of you comment on that a little bit.
You have a minute.
Yeah, go ahead. Hurry.
I don't have a good answer for that in a minute. How we get it all lined up. I mean, if we have communities who are interested in these big questions, and you know where this is going, Jeff, and we work through the rich resources of particular traditions, we may be able to align, but I don't think you solve disagreement if we're talking about people in different kinds of communities.
When I think about the AMA's position, they still use this very wonderful statement that says that assisted suicide is fundamentally incompatible with the physician's role as healer. So if you just take that statement and ask, well, what does science say about that? Well, as I say to my medical students, your textbook of internal medicine will not give you the answer to this question. These are the presuppositions, the prior commitments that guide all of our thinking in the moral realm. I think that we can learn tons from the Socratic tradition onward to the rest of Western and other civilizations, the goodness of asking questions, and to help people, to encourage each other to think seriously about all the details that are relevant, and to point out, though, that the differences, to say, listen, we are all coming from somewhere. The roots of our moral reasoning start somewhere, and we have to then be willing at a certain point to be candid about our starting points, agree to disagree, but also do our best to persuade folks toward what we believe is a better way.
All right, let's thank our speakers.